I had presented this paper last year. It's a keynote address. It received the Hardia award last year. So I'll be talking about the algorithmic approach to plan a laser-based cross-linking in progressive keratoconus. We know the advantages of a laser-based cross-linking. There is an improved asphericity, so there is an improved contact lens fitting, and also a better spectacle acceptance. So the standard of the laser-based cross-linking is actually for the corneal thicknesses of more than 450 in eyes with keratoconus. And what we do in this is we flatten some of the corneal apex as well as an adjacent arcuate area. So we create a central bump, thereby mimicking a myopic cornea, which is usually the normal. So the problem comes when there is a maximum ablation of more than 40 microns, or if the initial corneal thickness is below 400 microns. So in these cases, we have established something called the TREC. So what we do in this is we ablate the zone of the cone, and this results in a minimum ablation, while at the same time giving us the benefit of a laser-based cross-linking, that is by regularizing the cornea. And so we are able to do this for corneas which are less than 400 microns. So the question that we asked was, can we compute an algorithm for safe and effective laser-based cross-linking in keratoconus, and if these had good long-term outcomes? So we recruited 300 eyes with the inclusion and exclusion criteria and the ethics committee approval. The patients who presented with a documented progression on pentacam were also evaluated on the Schwind and Osiris-T, and we classified them into two groups based on the corneal thickness. They underwent a topo-guided PRK or a TREC depending on what the thickness was and what the ablation was after planning. I will be discussing that for subsequently. This was followed by an accelerated corneal cross-linking, and their visual function, tomography, and biomechanics were seen at 1 month, 3 months, 6 months, 1 year, and at 5 years post-operatively. So how did we decide whether they will undergo a routine laser-based cross-linking or TREC? We took good scans from the Phoenix software, and we exported them to the Schwind software, where we used the ORC-CAM mode. So in this mode, we first applied the zero rule, and then we saw the ablation depth while treating only the higher aberration. That is, we did not treat any refraction. After this, we click the manager tab, which gives us the higher order aberrations. And when we click on the depth minimize, it again lessens the amount of ablation by correcting only the significant higher order aberration. So as you can see here, it has only corrected the vertical and horizontal coma and switched off. What that means is it is not treating the higher, the spherical aberration or the trefoil and other fourth and fifth order aberrations. So here we can see So here we can see that the central and maximal tissue ablation in the brackets came down from 28 to 19 and 8 micron central ablation. But if this is not the case, if we have a higher ablation after doing all this, this might cause an excessive tissue ablation and scarring. So in these patients, we performed a TREC by localizing the steepest area of the cone by measuring it on the cirrus and then planning a PTK on the Schwind software. So this is just an algorithm to show how we proceeded. Basically, if there was a thinner cornea or if there was a higher ablation planned on the TGPRK, we planned a TREC. And what were our results? So in terms of the efficacy, we saw the UDVA and CDVA, and they were comparable for both the TREC and the TPRK groups. And the safety was seen by the gain of lines, and we saw almost 40% had a gain of lines in TREC and 42% in TPRK, which was significant. And they both had a spherical equivalent accuracy which was comparable, and both showed a reduction in the corneal astigmatism post-surgery. They also showed a reduction in the refractive astigmatism post-surgery, which could be attributed to a reduction in the corneal aberration, so there was a better spectacle acceptance, and that reduced the refractive astigmatism. We also saw a flattening of keratometry in both the groups, which was comparable. So we did come across a few complications. Approximately 2% patients progressed 5 years post-TREC, and 1.5%, that is 3 out of 200 patients post-TPRK. These were treated with the Dresden protocol subsequently. We didn't see any excessive flattening in patients who underwent TREC. There was 1.17% flattening in the TPRK group. And we did see a loss of lines in 3 out of 100 patients in TREC and 2% in the TPRK group at 5 years post-op. So to conclude, a topo-guided PRK cross-linking can correct the irregularities and give refractive improvement to patients with keratoconus. And a TREC has shown a similar magnitude of flattening while conserving greater amounts of tissue. So it can be considered for patients who have a thinner cornea, decentered cones, or advanced grades. and it is comparable to TPRK in terms of safety and efficacy, even on long term, that is 5-year outcomes, and the application of this algorithm showed promising results. Thank you.